We had a particular problem with Clostridium difficile on one of our wards, J19. Having had 2 years with just one case of Clostridium difficile, this ward saw a run of cases that amounted to 12 in 12 months. Each case had, of course, had a full root cause analysis, and really these root cause analyses hadn't been identifying what was going on.
At the start and during the process, it was a very stressful period, and I found it very challenging as a ward manager. I struggled at times to know what else I could do. I spoke to every member of staff, I supported them, I reassessed everyone's hand hygiene, and I reassessed everybody coming in and out of source isolation. I feel I did a lot of work to try and prevent future cases of Clostridium. And I've struggled at times actually keeping myself motivated. I've kept everybody going and supporting everybody, but occasionally have struggled. And when we did have another case, it did really knock me and the team down, but I did think, gosh, how are we going to get it and go ahead and pick ourselves up again?
Every time anybody had loose stools, they were all went into a state of panic, waiting for the results to come back. We were all getting to the point where nobody knew what else we could do. So, because the same people are involved in the RCAs, it was, well, are we missing something? Do we need the involvement of somebody else?
As a ward team, we've all felt, as each infection has come across, when we get a telephone call and we get the information that another Clostridium is on the ward, we've all felt really upset and emotional, and it's been very difficult as a ward manager trying to keep everybody going and keeping everybody motivated through everything, because the whole team have felt like it's their fault.
My involvement with the whole process really was right from the start when we got our first infection of Clostridium difficile. And then from there, every time they got other ones, going to the wards, doing audits, and looking at practice really, and trying to figure out what was going wrong, if anything was going wrong.
It was beyond me and my team of what I could do to stop this happening to the patient.
It felt extraordinary to me that we were having this number of cases of Clostridium difficile in one geographical place where there was no evidence of transmission. So it felt like we should have an extraordinary response to it, something that we hadn't done before.
So collectively we had the idea of a summit to address this, and I wanted to bring in senior staff from the organisation to get some real power into this and to be sure that we got proper engagement and people understood this was something important and serious.
In order to prepare for the summit meeting and for us to learn more about this problem, several of the junior doctors were tasked at looking at risk factors in the patients generally on the wards, and also in relation to those patients that developed Clostridium difficile.
The process to get to the summit was really difficult. Difficult for the staff, difficult definitely for the patients, something that we would not want to go through ever again.
The summit meeting itself was a very useful experience. It was an opportunity for everyone who was involved on J19 in any capacity to really get together and consider whether everything had been addressed that could possibly reduce the incidence of new cases of C. diff on the ward.
At first I was quite worried about going because I thought it was going to be targeted at me and my team and what weren't we doing right, but it was really productive where everybody talked about the good that we've actually done on the ward, that the hand hygiene's good, the source isolation, documentation, everything's really good. We get good feedback from the infection prevention team.
The staff on the ward affected were completely engaged in this.
One of the things that I felt at the meeting, that finally we had the chance to speak to everybody that had a vested interest in this problem.
We had people there that hadn't been involved in all of our processes, and they were able to review what we'd done and identify if there was anything that we'd missed.
There were 2 junior doctors at the meeting who gave a very impressive presentation. They'd analysed antibiotic use and they had concluded that there was perhaps some unnecessary antibiotic use.
We found that the patients who had this serious infection had been admitted on multiple occasions prior to the index admission. And during those previous admissions, they had received several courses of antibiotics. And this may not have been recognised by the doctors treating the patient at the time.
My role in the summit was really to look at the risk factors of all of the cases that had happened and what were the common themes linking them and what could we learn from that. And one of the things that we did notice coming out of J19 was their antimicrobial prescribing and the oversight from senior doctors, which we thought was really important.
So the learning point from this is that the junior doctors should not just refer to the admission booklet that they are using, but should look through the general notes to learn about all recent admissions and past medical history, and in particular to find out about the numbers of antibiotics that they'd had prior to the index admission. We found that these patients may receive up to 8 courses of antibiotics during one hospital admission. And not surprisingly, the patient who did have the most antibiotics then developed Clostridium difficile.
Each case that we had was a different ribotype. They were all completely different cases. I reassured every member of staff that it wasn't cross-contamination, that they were really having good practice with the hand hygiene, with the source isolation, with caring for the patients. And we have a lot of patients who are confused and wandering and go around touching all the other patients' equipment, linen trolleys, notes trolleys, and so we have extra cleaning of all the equipment on the ward, extra touch point cleaning.
We got them to do extra cleaning 4 times a day for the toilets. We'd like to introduce that everywhere because I think that's a really important thing. We worked very, very closely, multidisciplinary approach to this incident.
A lot of the patients don't naturally wash their hands after going to the toilet or before they have a meal, and we go around as a ward team and offer hand wipes, and when they're coming out of the toilets ask if they have actually been cleaning their hands.
The sort of lessons we've learned from J19 have been very informative in framing our 14-15 HCI action plan going forward, so that when prescriptions are made by less experienced doctors, particularly out of hours, that they're quickly reviewed by more senior experienced doctors, so we ensure patients are on the right antimicrobials, and indeed if they don't need them that they're stopped sooner rather than later.
At board round every day we discuss every patient and we talk about if the patient is on antibiotics and do they actually need them. The new drug charts that the Trust has implemented, actually after 3 days we look at whether the antibiotics need to continue, and I feel it's quite powerful for the staff because they can actually stop and say no, we're not giving any more until that's reviewed, and the staff have felt empowered and they actually can do that and can challenge the doctors and say the patient's improving, do we actually need that anymore?
It was supportive. It made us feel that the things that we'd done and we'd put in place had been the right things, and we could continue to do those and make it more a positive experience for the patients and the staff.
The nursing staff were able to articulate really clearly, really strongly how they felt and what they'd done, and I would recommend it.
Particularly the ward felt supported, because I think at one time they felt very vulnerable.
The ward, through endless hard work, had probably put in place all the things which were necessary to address the problem.
The summit was really good. It was kind of like a coming together and hopefully an end to the incident, because we haven't had any more infections on there for about at least 2 months. So it's been really good.
Now we're through it, we're past that period, and we're moving forward and planning new ways of doing things on Ward 19.